morning everyone. I'm Dr. Joshi Akash Dinesh, presently work in UN Mehta Institute of Cardiology and Research Center. I'll be discussing today aorto pulmonary window. I'll be discussing the topic in the small subsections, like first we'll starting with the introduction, second with the historical note, third is morphology and natural history, fourth is clinical presentation, coming to investigation, and then finally surgical management. So coming to introduction, basically AP window is a rare congenital heart defect between ascending aorta and the pulmonary artery. But one important thing we should remember here is that it has separate aortic and pulmonary valve. So that is how it's differentiated from the truncus arteriosus. So AP window has separate aortic and pulmonary valves, whereas truncus arteriosus has a single valvular trunk. And it occurs mainly because of the maldevelopment of truncal and aortopulmonary septum. Many books have labeled as with different synonyms. Some books have mentioned aortic and septal defects, aortopulmonary fistula, and aorticopulmonary window. Kirkland has mentioned all three names along with aortopulmonary window. Historical note: it was Elliotson in 1830 who gave the terminology of AP window, followed by Robert Gross in 1952, who did the first surgical ligation. And in 1954 at Mayo Clinic, it was first divided on the CPV after the given invented in 1952, followed by Johnson's technique came in 1978, and recently now in the early 2000s they have also did the Kuwata has also did a vascular clipping of the AP window. Incidence and epidemiology. It is general, all the literatures on the web says around 0.1 to 0.6% of the incidence throughout the world. India has reported 0.3 of incidence of AP window, and Western world has around 0.6% of AP window of incidence and epidemiology. It is usually has a male predominance. Is most commonly associated with interrupted aortic arch of type A, followed by right aortic arch and tetralogy of Fallot. There are multiple classifications given for AP window. Many have mentions about Richardson's classification, Morris classification, and Society of Thoracic Surgeons classification. So this is basically Morris classification, which has type 1 as proximal defect, type 2 as distal defect, type 3 has total defect, and last is intermediate defect. So type 1 proximal defect is a defect in which there is a well-formed superior margin, but inferior rim is not so very well formed and has a separate aortic and pulmonary valve. Type 2 is distal defect, where the inferior margin is very well developed, but superior margin is not developed. Superior margin is poorly developed. Type 3 total defect is a combination of type 1 and type 2. An intermediate defect is added by a Society of Thoracic Society of Thoracic Surgery, which has a clear superior as well as inferior margin, and this is a subset which is most commonly favorable for a device closure. Same thing, this image has been taken from Kirkland, which mentions type 1 as a type 1, type 2, type 3, and intermediate defect, which I have just explained. Coming to pathophysiology, aortopulmonary septum develops around 9 weeks and further into truncus arteriosus, and the failure of septation of the septum leads to deficiency in the aortopulmonary septum, leading to AP window. Physiology of the disease is same like large PDA and VSD, where there is overflowing shunt. It is the size of the defect that determines the shunting. So the large AP window will have a large volume shunting, small defect will have a small volume shunting. So, and also the postnatal SVR and PVR. Initially in antenatal phase, the PVR will be very high, so there will not be lungs will not be flooded with the volume. But as the PVR comes down, there will be volume overload changes. X-ray will become plethoric. Patient will come with volume overload changes, and that's where early closure is recommended. As soon as finally, if not close, patient will develop irreversible changes and may mostly dies by second decade. So how the patient presents? The patient will present with tachypnea, then failure to thrive, recurrent respiratory infections, and diaphoresis. So as I told you, it will present mainly like a PDA or a VSD. It's all features of PDA and VSD: tachypnea, failure to thrive, respiratory infections, diaphoresis. Signs are same like of severe PH. Patient will present with severe PH, so intercostal retraction, bounding arterial pulse, wide pulse pressure, systolic murmur. So differential diagnosis are PDA, truncus arteriosus, and a large VSD. The three main duties of AP window. Coming to investigation, basic investigations that we do: ECG, echo, X-ray, and cath. Okay, cath not required for all the cases, but ECG, echo, X-ray is must. ECG showing biventricular hypertrophy or LV volume overload with right ventricular hypertrophy. This ECG shows LV volume overload. We can see lead V2, V3, V4, V5 showing LV volume overload and right ventricular hypertrophy. X-ray, as you can clearly see, there is a cardiomegaly because of the large shunting, and X-ray will usually be plethoric because of the volume overload changes, lungs getting flooded with the volume, so plethoric changes. This X-ray is slightly plethoric but not very high plethoric changes seen. Echo we can see in the 5-chamber aorta and pulmonary artery, where we can see the AP window mentioned here. I have pointed the arrow where we can see the AP window. MP has mentioned RA, RV, aorta and AP window in between. This is the cath view, where you can see the cath, the wire is coming from the descending femoral to descending aorta into the aorta, and through the aorta we can see the, as we are giving the dye, it is shunting through the AP window into the PA. Coming to surgical management, different techniques has been mentioned. The technique mentioned the Kirkland is like similar patch closure, like we'll be establishing the bypass with aorto bicaval or aorto RA IVC cannulation, followed by snaring the RPA and LPA, opening the defect transverse incision on aorta, identifying the AP window, and followed by patch closure. And patch closure starts from the posterior wall. We should be very careful by doing by locating the left coronary artery. Usually is very near to the defect. Okay, this is I've taken this video from YouTube. I thought this is a very good video to explain. Now we can see as a CPB has been established with aorto RA IVC cannulation. Aorto pulmonary groove has been dissected. Now the surgeon is looping the aorta. Okay, the aorta has been looped. Okay, so that the self looping the aorta has been looped. Cardioplegia cannula is in situ. Plegia cannula has been taken. Okay, plegia is now delivering. Okay, branch PAs are snared and aorta has been cross clamped. We can deliver the plegia. So plegia has been getting delivered. Now as we know, RPA has been sent, pulmonary veins has been shunted to the interator septum. Now marking stitch has been taken at the AP window side. We can take 2 mark stitch on both sides, where to locate the AP window and to take the incision in center of the marking stitch. So now the incision has been taken, the AP window side has been incised. Okay, just take a small nick, don't incise the full with the entire blade, because you might be there's a chance that you might damage the valve or the coronary artery as well. So now as you open the window, identify where is the coronary artery. Okay, identify the coronary artery's valve and then go ahead with the incision. So now the entire AP window has been opened. We can see the AP window, the coronary arteries, look for the valves, measure the size of the defect, how big is the defect using the silk. So now we are measuring the size of the defect. Okay, that's the size of the defect. Now we need to take the same size of the patch, so we can use the silk to measure the patch. The patch has been taken. Usually many of the surgeons use pericardial patch or PTFE patch. 0.4 mm PTFE patch has been used. Suturing starts from the posterior wall. Okay, so now this is a sandwich technique. So it will be aorta, the patch and the PA. The patch will come in between, will get sandwiched in between the aorta and pulmonary artery. So that's the suturing start from the posterior wall with continuous suture technique. Some people also prefer surgeons, interpreted surgeons, suturing the posterior wall with the PTFE patch. So the bite is coming from the aorta to the patch and the PA. So now placing the patch in the at the side of the AP window. Okay, we have to make sure that the valves are at a safe position and the coronaries are not in the bite and not in the suture line. So placing the patch down at the AP window side, and then we will be doing the continuous suturing of the posterior wall, closing the AP window. So as the first bite, we are suturing continue the posterior wall with the PTFE patch. As we continue closing the patch, we can see the borders of the AP window clearly, and make sure we don't include the coronaries or any valvular tissue. So then once the patch AP window has been closed, aortic and pulmonary Yeah. As we saw, the pericardial patch was placed in the PTFE patch was placed in between in the aortic AP site between the aorta and the pulmonary artery. So now the patch will act as a sandwich between the aorta and pulmonary artery. So patch is in between. After the patch closure, we can close the aorta directly and go for deconvolution and weaning of CPB. So thank you for the this thing. I have taken much of the material from the Kirkland itself, and surgical video I got it from Academic of Cardiac Surgery as a YouTube channel. I really enjoy watching the videos out there, and some of the classic images of X-ray and ECG has been taken from Approach to Congenital Heart Surgery by Dr. Vijay Lakshmi. It is a wonderful book. Thank you.